So thank you for joining us today for the Illinois Cancer Partnership's Cancer and Genetics webinar. I am Linda Casbeyer with the Illinois Department of Public Health, the Comprehensive Cancer Control Program Manager. And with me today, acting as hosts and facilitators, are Dr. Keith Naylor, who is an assistant professor of clinical medicine, cancer researcher, and practicing gastroenterologist at the University of Illinois, Chicago. Dr. Naylor is also the acting co-chair of the Illinois Cancer Partnership Screening and Early Detection Subcommittee and clinical director of the University of Illinois Health Gastrointestinal Cancers Prevention Program. And our other co-chair, host and moderator, is Dr. Neil Perlman, who is a physician who is board certified in internal medicine, and he is currently the medical director of a not-for-profit organization for familial cancers, C-Care Lynch syndrome. So I will go ahead and turn it over to Dr. Naylor.
So I'd also like to take the opportunity to thank all the participants for participating today, as well as to also welcome everyone to the webinar. I hope everyone finds it very useful and helpful to learn more about how genetic testing can help with cancer prevention and control. And as Linda mentioned, we'll be going into our first speaker. I did want to mention that everyone could put any questions into the chat, and that we will also be including the information about our speakers in the chat as well if you don't arrive in time to hear the introduction. So at that, I will turn it over to Dr. Perlman to begin our first presentation. Thank you.
Keith, thank you for the excellent introduction. I am Dr. Neil Perlman. I wish I could go over everything in 15 minutes about the entirety of hereditary cancer, but I'm going to be highlighting on the most common conditions today. Can you see my slideshow?
Yes, we can.
Okay, thank you. We can't talk about hereditary without going through DNA. DNA has pairs of adenine thymine with cytosine guanine. And there are two types of genetic conditions. Autosomal dominant is the most easiest to transmit. You have two genes making up a trait. You only need one gene for an autosomal dominant condition to become an active condition. With autosomal recessive, you need both genes to make up the condition. So for autosomal dominant, if one parent has one gene, you have a 50-50 chance of getting it. For recessive conditions, both parents must be at least carriers of it. If they're both carriers, you have a 25% chance of transmitting. If they're both have active disease, you have a 100% chance of getting it. Because of the growth of genetics over the past several decades, in 2004, the CDC set up EGAP to help educate physicians about the nuances of genes. Now, as you know, breast cancer is the second leading most common cause of cancer in women. Almost 300,000 people got it last year. It's expected to be about 1 in 8 women have it. Men do have a risk of getting it, although it's not as common. There's over 40,000 people expected to die from it this year, 530 men. Colon cancer is the third most common cause of cancer in our country. Over 150,000 people get it each year. About a third of those people will eventually pass away from it. Well, a quarter of all people that have colon cancer have some family history of it. 5% have been found to have a known genetic cause, with the most common being Lynch syndrome. Now, Lynch syndrome is not as well known as the BRCA or breast cancer gene, but it's actually a bit more common. Almost 1.2 million people in the country have it. yet only 2% of people actually know they do. BRCA is much more common in Ashkenazi Jewish families. Now, with the BRCA or breast cancer gene, depending on the subtype, you have an increased risk of breast cancer. But besides breast, there's also extra breast cancers such as ovarian cancer, pancreatic cancer. So with the BRCA1 type mutation, by the age of 70, 39% have a non-breast cancer in their lifespan. Lynch syndrome is not just colon cancer, but it also affects the uterus, the ovaries, the pancreas, and there's 5 different subtypes of it. And this is a Lynch syndrome family tree. It's near and dear to me because it's actually my family. As you can see, my mom had early onset uterine and colon cancer, and then her 3 children all got cancers in their young 40s. I'm fortunately still alive along with my older sister, but my younger sister had colon cancer at 41 and passed away a year later. Because of that, we set up the Colon Cancer Alliance for Research and Education for Lynch syndrome, and we're trying to promote the different cancers that Lynch syndrome has. Now, EGAP had looked extensively at breast cancer because they're trying to figure out who should be tested and who should not be tested. So the average risk, which is the general population risk, are people that have had at most 1 second-degree family member with cancer in one breast diagnosed after the age of 50. And in that case, genetic testing is not recommended. Now, if you have more advanced or moderate risk, those are people that have 1 or 2 first or second degree relatives, but still over the age of 50. And it's recommended not to do testing unless they're of Ashkenazi or Eastern European Jewish descent, because as I showed you earlier, the BRCA gene is much more prevalent in this population. Now, the high-risk people are the people that have had breast cancer under the age of 50, triple-negative breast cancer, if you have male breast cancer, breast and ovarian cancer, if there's breast and pancreatic cancer in the family, or breast and prostate cancer in the family, especially high-grade prostate cancer. Now, with colon cancer, there's multiple different types of cancers. Lynch is the most common type, and it affects something called a mismatch repair mechanism. So on the first slide, I showed you ATGC with the DNA. In Lynch syndrome, you have a problem with the body spell checker, so you can get a copy of the DNA in a new cell that's not in the correct matched up part. It is an autosomal disease, so you only need 1 gene from 1 parent to pass it on. And with Lynch syndrome, you have a very high risk of colon cancer. Average age is 44, which happens to be when I had my colon cancer. Now, the current guidelines for screening for colon cancer were lowered from 50 to 45 for the general population. But if Lynch people follow the general population guidelines, you're going to miss over half the cancers. So that's why it's important to identify people with Lynch syndrome. There's also a high risk of uterine cancer and ovarian cancer. Again, average age is in the 40s. And depending on the subtype of what you have different types of risk factors. MLH1 is the biggest subtype. MSH2 is the second biggest, but most common in Ashkenazi Jewish families. And then the risk changes depending on the subtype. This slide kind of goes over the common cancers that Lynch has. And as you can see, there's a big difference between the general population of like 4.5% for colorectal cancer to about 70% in most studies. Ovarian cancer goes from 1.6% to about 13% on most of the subtypes. The second most common is familial adenomatous polyposis, and that's the APC gene, also autosomal dominant. MAP is a recessive condition. I have the genes highlighted. We also have juvenile polyposis syndrome, another autosomal dominant with the genes highlighted. Peutz-Jeghers, Now, when someone has colon cancer, if you're trying to do genetic testing, you're not going to get the results immediately. It takes a few weeks. So there are different tests that are done in the hospital that have a very quick turnaround time. The most important thing is MSI or microsatellite instability testing. And what microsatellites look for are there's regions of the DNA that have repeated segments that are all supposed to be the same length. But if you have a mismatch repair mechanism, so ATGC are not being correctly matched up, you're going to get replication errors and you can have very long regions or short regions of that DNA. And this is important not just for discovering is there, a genetic problem, but it's also for treatment because medicines like the immunotherapies such as Keytruda work very well with MSI positive tumors. And this is a pictorial of what microsatellites appear to be. IHC screening looks for proteins that are supposed to be made by the genes. And you can actually do a stain for it and see, do you have it highlighted? So in this screen, MSH2 and MSH6 are properly stained, so they're working properly. But MLH1 and PMS2 are not stained. So that means there's either a genetic problem, causing it not to be made, or there's something known as a BRAF mutation, which is not hereditary cancer, but it causes a goof up on the lab test. Because this is a little confusing, I do have an algorithm that you can go through. So normally if you're missing a protein, a lot of times it's Lynch syndrome, but there is the BRAF factor. Now, genetic testing is nice because you can get a nice yes/no answer most of the time. And EGAPP now recommends genetic screening for all patients with colorectal cancer, but that's not the case in all the organizations. For example, the NCCN recommends screening for Lynch syndrome if you have early cancer below the age of 50, if you have first-degree relatives with a Lynch cancer below the age 50, or if you have multiple relatives with different Lynch syndrome cancers at any age, or if a person has multiple cancers that are related to Lynch syndrome, such as like when my mother had both colon and uterine cancer, that's high risk for Lynch and she should have been tested. Now, when you do testing, you can do a single gene or you can do a large panel. 15 years ago, when tests were over $1,000 for each gene, it didn't make sense to do a panel of 70 tests because that would be extremely expensive. But now you can get panels anywhere from $250 to $3,000. An example of Quest Labs, you can choose the breast cancer, the colorectal cancer. You can do individual tests for all sorts of diseases, and you can do a comprehensive 66 gene panel. Now, Quest Labs charges a little under $3,000 for almost all their panels. And if you ask them to pay not through insurance, they actually charge you a few $100s more. LabCorp, interestingly, charges the insurance companies over $3,000, but if you want to pay in cash, they'll charge the person just $2,500. You do get a better deal from the genetic testing companies, and I'm listing a few of them. Invitae is a very nice one where you can get a 70-panel gene test or a BRCA panel, and you're paying just $2,750 through insurance. But if you do a self-pay or direct pay, it's just $250, which is a lot more affordable. Invitae's 70-panel test goes over all these conditions, which is a lot. Myriad Genetics is another excellent company. They have a 48 gene panel, which does breast, ovarian, colorectal, etc. And they also charge $2,000 to $3,000, and you can do a direct pay of $249. Now, Color Genomics, we have to thank for getting the $249 price because they started pricing all their tests at $249. And what's nice about Color, which differentiates them from other companies, is that they'll include a genetic counseling session at no charge, with their testing, so you can do a direct-to-consumer test rather than the physician test, which is what the other companies are. Now, they have a nice for their panel testing for both hereditary cancer, hereditary heart health, and medication response. So if you don't want to spend $300 a month on a medicine that you don't have the right gene, so it doesn't process right. These are the different genes for those panels. And where it comes in handy is, as I said earlier, normally high-risk people are the people that are designed to have these testing. But everybody says, should everybody be tested or not? Now, the CDC lists 3 conditions: Lynch, hereditary breast and ovarian, which is the BRCA, and the familial hypercholesterolemia, because those can all be treated either with cholesterol medicines, diet, exercise, preventive surgeries. And there was a study done last year, published in the Annals of Internal Medicine, which looked at those 3 conditions and said, if you test everybody and the test only costs $250, at the age of 30, does it make sense to screen everybody in the country? And they figured out, yes, it was cost effective. And at the age of 40, as long as the test was $290 per test, it was still cost effective. At the age of 50, the test had to be less than, it was $166 or less. So since the test you can get for under $250, it does make some financial sense. Of course, there are other risks and pitfalls with testing everybody. Now, the benefits of testing is you can do preventive colonoscopies, mammograms. You can do MRI mammograms for people with BRCA. You can do preventive surgeries such as a mastectomy or a hysterectomy, so you don't get uterine or breast cancers. And you can also take certain medications which have been shown to lower the risk of breast cancer or colon cancer. And we know from other studies, and this looks at breast, cervical, colorectal, lung, and prostate cancers at stage 1 or stage 4. And as you can see, the survival is much better at the earlier stages, and the cost of treatment is also a lot less. Now, the pitfalls are you do have insurance issues. People get very stressed or depressed if they have a genetic disease. And sometimes you have unclear results. So instead of getting yes or no on the genetic test, you get a variant of unknown significance. There's also family discussions you have to do, and there's the cost of testing. Now, because insurance, rates vary for people, there was the GINA Act, which protects health insurance, but it doesn't protect disability, life, or long-term care insurance. So there are some states that have been looking at starting state laws. Florida has passed them, so it prevents people from getting very high, inability to get life insurance or disability because of genetic conditions. Illinois has something called the Illinois Genetic Information Privacy Act, which started in 1998, and it prohibits insurers in our state from asking if you have a genetic test results for health insurance and accident insurance, but it doesn't do anything for life insurance or disability insurance. Now, if your sister has breast cancer from BRCA1 and you've been tested for BRCA1, you could provide that information voluntarily to the insurance company so your life insurance rates won't be as high, but the insurance companies aren't allowed to test you without your permission. In 2019, it was updated. So if you have a home health direct-to-consumer genetic testing company like Color, they're prohibited from providing that information into the insurance database without your express permission. If there's positive testing, you have to test the family, and our genetic counselor is going to be discussing that further. And genetic counselors are also excellent individuals to help walk everybody through the problems associated with a positive testing. And for the cost of testing, as I said, it could be $3,000 range or it could be the $250 range. There is a nonprofit, Mayberry Memorial, that started a Project Conquer, which does provide aid for people that are trying to get their family members tested, for Lynch syndrome. And that is the summary of hereditary cancer testing in 15 minutes.
Thank you so much, Dr. Perlman. That was, a tremendous amount of information. I do want to mention to the attendees that this is taped. So if you'll have an opportunity to look at the taped version, if you want to take a closer look at the slides and weren't able to see everything on first listen, and please as well place any questions in the chat, and we'll have an opportunity to have a question and answer towards the end of the discussion. But I'll have the distinct pleasure to introduce our next speaker, who is both a friend and a colleague. That's Dr. Tara Maga, who is our senior genetic counselor here at the University of Illinois Health. She's been active for 10 years in that role, also as an active researcher with research looking to improve access to genetic services. In addition, Tara is a faculty member at the Northwestern University Genetic Counseling Program, as well as a clinical instructor in the Department of Medicine here at the University of Illinois College of Medicine at Chicago. So I'd like to turn it over to Dr. Maga for a presentation. Thank you very much.
All right, thank you so much, Keith. I am thrilled to be here. I'm going to share a little bit about what we're doing at our cancer center at UI Health in trying to access, increasing access to cancer genetic counseling services. Okay, so just a little bit about the population that we serve here at UI Health. Primarily, we serve patients in Cook County, which is home to more than 40% of the state's population and quite diverse in race and ethnicity. Compared to other counties in the US, Cook County does have higher rates of poverty, lack of health insurance, severe housing problems, violent crime, and air pollution. It has been designated by the federal government a medically underserved area. And so who we are at our cancer center is we are on the smaller side of cancer genetics clinics. We have 3 genetic counselors. 2 of us, including myself, are housed in oncology, which is where our program started. But recently, in the past few years, we have added another genetic counselor who is housed more in primary care, which will become important for the next few things that we talk about at our Miles Square Main Clinic, which is a federally qualified health center. Our referral sources come from many places. Many of our providers here at UI Health refer within our own system, but we also get significant amount of referrals from community hospitals in the Chicagoland area, as well as community clinics. We both do traditional counseling where people refer to us for both pre-test and post-test counseling, where we're doing the testing for the patient, but we also provide just post-test counseling. This is, of course, most important in situations where an oncologist is testing their patient or a breast surgeon. It can't wait for them to come to an appointment with us. And then only if they find something do they send their patient for our services. Recently, we've also cultivated a relationship with the VA, so they are sending many of their people within the Chicagoland area to our clinic for genetic counseling and genetic testing because they have long wait times currently. Most important, we provide different models of this, models of care here at UI Health. We have found that it is important to have multiple options for patients. Patients have different types of barriers. So we both have in-person appointments, telehealth appointments, and most recently we've started offering group telehealth appointments. We'll let you all know how that goes very recently this month. Of course, telehealth, when the pandemic hit, a lot of genetic counseling programs pivoted to telehealth appointments. Also, of course, very good at overcoming barriers, especially for rural populations, getting access to these appointments, and for people who have issues with transportation. But we have also found that telehealth is not the right option for all people, and they wouldn't prefer it. Things like housing insecurity, unreliable internet services, and sometimes people just live with many family members and there isn't a place in their home or their house where they have privacy to do these appointments. So again, important to offer multiple options for multiple different types of needs. So today I'm mostly going to talk about some of the projects we have ongoing to increase access. And so just to frame this, the traditional population health approach to breast cancer screening is, of course, this age-based paradigm where everybody gets screened at the same age, assuming everybody is at average risk. One size fits all. We know, and most people on this call know, that that is probably not the best way to do cancer genetic screening. And instead, we need a precision medicine approach to cancer screening and prevention where we do it based on risk. Of course, the biggest risk of people are going to have the general risk, and those folks can get general screening. But as these risks increase and the group gets smaller, people may need more than that, starting at earlier ages, getting additional screening tests, and even prophylactic surgeries or medications that reduce risk. And so this is just to illustrate this further. You have people who have no risk factors who get that general population screening, compared to people who may have reproductive risk factors, family history. These folks may get breast MRIs for breast cancer screening in addition to mammograms, possibly talking about medications to reduce risk. And then those people who have hereditary risk are the people we're mostly talking about prophylactic surgeries to reduce their risk for hereditary breast cancer syndromes. So thinking about the systematic breast cancer risk assessment, and this can be widened to colon cancer, of course, as well, thinking about Lynch syndrome, which we just learned about, but using this as a standard component of primary care to reduce breast cancer disparities or just cancer disparities. And there's been a lot of work on the feasibility of implementing this screening in primary care clinics, OB-GYN. Of course, OB-GYN clinics miss out on screening people assigned male at birth. So we're really pushing more towards PCP clinics where everybody has appointments, and then breast imaging centers. Here at UIC, we're doing a program called MyFamCam, which is a QI initiative to increase the identification of adults who are eligible for counseling and testing. This is a 5-year quality improvement project, and we're looking to expand to all 8 Mile Square health clinics, and then eventually across our health system. We have also recently expanded into Mammo. The point of this is to implement evidence-based universal family history screening, so not leaving it up to not leaving it up to chance of who your provider might be, and do this for all adult patients in primary care, and rescreening at 1 to 2 year intervals. We're also attempting to address potential challenges and inequities in this, including health literacy screening and navigation. Navigation, we have found, is so key in any of these programs, and providing no low-cost genetic counseling and testing. So far, this program has screened over 1,300 people. 21% of those patients screened as high risk, meaning they needed a referral to genetics. Of that group, 70% were actually referred to genetics, and we found 7 patients where we found a pathogenic mutation. What's missing here, of course, is the number of people who were referred, and then who came to their appointments. We also see a large drop off in that area as well, which leads me to our next discussion. Access to services is important, and that's where it starts, of course, but as everything, it's more complicated than that, and it's not the whole story. It's this arrow. So once people are told that they should go to genetics, we need to have increases in uptake of these services and uptake of genetic testing. Even when they're referred, a number of patients never make it to see us. And we know that sometimes this is as high as 50% in our in the patients we serve here at UI Health. And so to address this, the GUIDE project was done, whose goal was to create a culturally sensitive educational intervention to motivate African-American women with hereditary risk to attend these appointments. It was important that this could be watched on a smartphone or other mobile device, and this was a collaboration between Governor State University and UI Cancer Center. And so just to review social determinants of health and disparities in genetic testing, and I know this is going to be talked about in our next discussion, but when we think about societal conditions, of course, we all know there's inequitable distribution of healthcare resources. We also know that there's poor reimbursement for these types of services. And most importantly, thinking about the history of discrimination and mistreatment in education, healthcare, criminal justice system, and research, which has led to low health literacy and mistrust, understandable mistrust in our healthcare systems. At the institution level, we know that the requirement for provider referrals is a huge barrier. Like I said, 70 is high for us, but 70% of people referred in that program, meaning 30% of providers never referred their patient. There's a lack of incentive for providers to refer, and we need to invest in patient navigation and IT. Also, at the provider level, failure to refer due to knowledge gaps, time constraints. These providers are are managing a lot for patients. Of course, there's implicit bias and ineffective communication. On the social context, lack of social supports, things like childcare, transportation, time away from work, especially for those that are paid hourly, they're losing money when they come to these appointments, potentially. Social factors, families, familial secrecy, cultural norms, influence of their social network, and then individual factors such as lack of self-efficacy, low health literacy, knowledge gaps, temporal orientation, competing life challenges, and out-of-pocket costs. So to address this, we use this model of behavioral prediction where our behavior that we're hoping to get is an initial consultation for genetic counseling. And to influence that, we need to influence a person's intention, right? If you have intention to do something, you're more likely to do it. And by that, we needed to understand attitudes towards genetic counseling. What did they expect, perceived social norms, and self-efficacy. And so this study was a qualitative research study. We did interviews, they did interviews and story circles. This is a group of African-American women who actually in a previous study were referred for genetic counseling, but never made it to the appointment or never scheduled an appointment. And so you can see with the demographics, we have a nice spread of age in this group. Most of these people had Medicare or Medicaid insurance. And then for annual household income, 55% made less than $30,000 and 45% made over $30,000. So again, nice spread there, nice equal, almost equal. And then of this group, 3 of these women made an appointment but never came, but the majority never made the appointment. And so themes that emerged from these one-on-one interviews and story circles that were really important and led to an intervention, which I'll briefly talk about, were that people had mostly negative feelings about these appointments, which really makes sense why people weren't coming to and this group of women weren't coming to the appointments. Commonly associated with a negative outcome, many equated genetic counseling with a diagnosis of cancer, even though we all know a genetic test, at least the type of genetic testing we do in our clinic, does not give people a diagnosis of cancer. They also feared they'd be told they had breast cancer at the end of these appointments or would develop it in the future. There were many discussions in the story circles about lack of trust, poor communication with providers, talked about instead of talked to. That's how they felt when they went to their provider appointments. And genetic counseling was not very salient to the participants. Very few realized what would come from these appointments. So again, thinking about what do you expect if you don't know what to expect or you don't think you're going to get anything, why would you come? Hope the hopeful thing though was that in this study they did tell them more about what would happen, and when they learned about it, they felt like it would be valuable to them and their families. And so it matters how we talk about this. You know, sometimes a provider might say, would you want a cancer genetic test? That doesn't mean a lot to people. What type of cancer? Does that mean you're going to test me for cancer? What will we do with that information? A little bit better, would you want to know if you were at increased risk of developing cancer? But again, for many people that we serve in our communities, you know, being told you're at high risk for something doesn't necessarily automatically make you feel good because you don't know what people are going to do to protect you, right? Is there something that can be done? So probably the best would be, would you want to know if you were at increased risk of cancer so you could have access to things like increased screening or other risk reducing options? And so giving them what the test tells us, but also what happens next? What are the ways we can protect people? You know, not everybody, even when they come to see a genetic counselor, chooses to do this testing, but overwhelmingly, I would say from my discussions with thousands of patients at this point, people want to still stay healthy. They want to protect their families. And so other themes that came were breast cancer was associated with family secrecy, familial death, again, negative emotions are surrounding these referrals, these appointments. Family secrecy was generational, multi-directional, and paradoxically associated with guilt and anger. Few people knew people who had had an appointment like this, and those that did, the person always had cancer. So this really wasn't being seen as something preventative, which is what we want people to see it as, but that wasn't these women's experience. And you're going to believe your life experience. For self-efficacy, things that we all know came up, cost, insurance, other health conditions, and then religion and spirituality served many roles in the lives of these participants. And so again, Normalizing, it's difficult to know what our relatives have been diagnosed with. Not all families have an open dialogue. Cancer is still very taboo in many cultures. You don't need to know everything about your entire family history to benefit from an appointment. I've had patients who had a mother with a young colon cancer, but didn't know anything else, that thought that that meant they shouldn't come because they didn't know their whole family history, when of course we would have offered them testing just based on their mother's history. And then lastly, just to talk about it, over 96% of our patients in our clinic pay $0 for this test in 2023. And so most patients don't end up paying anything. So this was just So those interviews, those story circles came to themes. We did scripts and storyboards. Those were shown to focus groups. And we did actually make a final intervention, which is a short video I'm not going to show today because I don't have the time. It's 6 minutes. This is the link. And every word almost in that video comes directly from these women's interviews and story circles and what was important to them, in hopes that we can increase intention to come to these genetic counseling appointments. Now, we've talked about influencing intention to create a behavior, but skill and environmental constraints, of course, also influence whether or not a behavior happens. To address that, we're thinking about changing the model of genetic counseling to point of care. This is already happening across the nation. We're doing it here at UIC as well, moving to point of care counseling on oncology, but also primary care. And so the last thing I'll just share with you is the Test My Genes project, which we're doing 2 arms to see if we can see a difference, where people are screened with MyFamCam. And then 1 arm would be enhanced standard of care, again, thinking about navigation as important in all of these plans that we're making, where these people are referred to genetics for testing, and then mainstream genetic counseling, where their PCPs initiate the genetic testing, and then triage the highest risk to us, people who test positive, people with strong family histories, regardless of results, or anybody who needs us, really. And then I just want to take a moment to thank everybody, all the amazing people that I work with at my job. And I've highlighted a few people who have really taken the lead on some of these projects. Pamela Ganschow, Vivian Pan for the MyFamCam and Test My Genes projects, and then Vita Henderson, and Beverly and Kent, who really, for that Guide Cancer Research project, took the lead. And thank you, everyone, for your time today and letting me share a little bit about what we're doing.
Thank you, Tara. Our next speaker is Lisa Hinton. Lisa is an MPH. She is an Associate Director of State Partnerships at the American Cancer Society. She has 20 years of experience in healthcare administration, along with cancer prevention and control. Previously, she has worked for Susan G. Komen, Stand for Her, American Hospital Association Institute for Diversity and Health Equity, the University of Chicago Medicine Comprehensive Cancer Center, Moorhead School of Medicine, National Center for Primary Care, and was a community health educator for the National Cancer Institute. So, Lisa, please take it away.
All righty, let me go ahead and get my video going. Okay, great. Well, thank you all for joining me today. I'm happy to be here. Let me go ahead and get the... There we are. Thank you for inviting me to be here to present on genetic testing inequities and efforts to increase access to care. Today, I'm going to share with you information about American Cancer Society's vision, mission. We're going to talk about health equity. We're going to talk about those social determinants of health a little bit more. We're going to talk about genetic testing inequities and efforts to increase access to testing. So American Cancer Society vision is to end cancer as we know it for everyone. Our mission is to improve the lives of people with cancer and their families through advocacy, research, and patient support to ensure everyone has the opportunity to prevent, detect, treat, and survive cancer. Before I begin my presentation, I'd like to open with a story. This story is about someone who was very near and dear to me. And the story begins with me at my car, taking my luggage out my truck, and this person, she approaches me and gives me the biggest hug ever and says, "Lisa, I'm so happy to see you. Haven't seen you in so long. How have you been?" And I told her, "I've been fine. I've been doing pretty good." She goes on to share it with me. "Well, you know, Lisa, I know you're working in the cancer field. What do you know about breast cancer?" I go, "Yeah, I know about breast cancer." She goes, "Well, you know, Lisa, I felt a lump in my breast and it's been there for a while. And, you know, I haven't done anything about it. You know, my mother passed away from breast cancer and my sister passed away from breast cancer. And, when they open you up and they cut you and the air hit your breast, then, that's when you die." So I stood there with her and I talked with her and I encouraged her to go and seek treatment. She went to go and get treatment and was diagnosed with stage 4 breast cancer. And she passed away within the year. And I think about her often. I think about this story because this to me is an example of, the system failed her. She was failed. And so, that brings me to health equity. We know that everyone should have a fair and just opportunity to be healthy and cancer free. And so did she. At American Cancer Society, we make health equity a strategic priority. And if you look at this model here, you see that it begins with people. We believe in helping people with the greatest need, prioritizing diversity, equity, and inclusion, addressing social determinants of health, and understanding the community's historical, social, cultural, and economic context. Um, Also leveraging the power of volunteers and valuing community expertise. And all of this has to be done in partnership with other organizations. Not one organization can do this work alone, which is really why I appreciate our partnership here with Illinois Cancer Partnerships. We need each other to be able to do this work. When I go back and I think about my friend that was very near and dear to me, and some of the social determinants that may have impacted her outcome, I know that she was an empty nester and she lived alone and, may have even suffered from some loneliness. There was some financial instability that she may have experienced. Likewise, she may have experienced some discrimination in the healthcare system because she was never referred for genetic testing and counseling, even with her strong family history of breast cancer. And then when I begin to dig deeper and I look at the literature, and what does the literature tell us about genetic testing inequities? And so it tells us that people from racial, ethnic groups, rural communities, people who are uninsured, underinsured, and those with lower education and income are less likely to receive genetic testing. It tells us that people from racial and ethnic groups are less likely to receive a referral for genetic testing. Our previous presenter, she talked on some of these things about, why, there may be some lack of knowledge among providers and there may even be some implicit bias. But, this is when we begin to talk about unnecessary deaths. These are deaths that do not have to occur. I think about my friend, and if she was maybe referred for genetic counseling, maybe she would have been able to have some preventive measures where her outcome would not have been her being diagnosed with stage 4 breast cancer and eventually passing away from breast cancer. This is a map of the Illinois Clinical Genetics Centers. And looking at this map, you can see the disparities in geographic locations where these centers are located. There's a heavy amount of the centers near the cluster in northeastern Illinois, central Illinois, you have Peoria, Springfield, Champaign, one in St. Clair, downstate Illinois. But when we really look at this map, it really sheds the light on disparities in access to care to these services, particularly downstate Illinois and in the rural communities. So with that said, let's begin to talk about solutions. So American Cancer Society offers extramural discovery grants. Investigators are able to submit their projects, which are peer-reviewed, and the best project is selected that benefit the cancer community. One such funded project includes the Gene Machine. We know that African American women have higher breast cancer incidence rates before the age of 40 than other ethnic groups in the United States. They are more likely to be diagnosed with triple negative breast cancer or more deadly subtype. These facts suggest that hereditary factors that are involved, yet African Americans are underrepresented in breast cancer research. Dr. Murner and her team utilizes the Gene Machine to travel throughout the state of Alabama, including rural parts of Alabama, to conduct genetic testing. Currently, American Cancer Society is funding nearly $500 million in research invested in more than 680 active extramural discovery grants. Another program American Cancer Society offers is through our Center for Diversity in Cancer Research. This program aims to build an inclusive research community that addresses cancer disparities by recruiting and nurturing people who are underrepresented because of race, ethnicity, gender, ability, or low economic status in the scientific and clinical training environment. We know that representation matters. It's people like you and me that will bring value to designing and implementing sustainable community solutions. No one understands communities, historical, social, cultural, and economic context better than us. There are opportunities through our Center for Diversity and Cancer Research to gain experience and exposure. We have our summer healthcare experience for high school females. We have our diversity and cancer internship for undergraduates. And likewise, we have our post-baccalaureate program for graduates planning to get a doctoral degree. And last but not least, we have the American Cancer Society Cancer Action Network, which is American Cancer Society nonprofit, nonpartisan advocacy affiliate. ACSCAN is critical to the fight for a world without cancer. Recently, there have been legislative efforts here in Illinois to which is a collaborative effort with Susan G. Komen. This bill was introduced just January by Senator Julie Morrison. This bill is looking to amend the Illinois Insurance Code to provide coverage without imposing any cost share requirement for clinical genetic testing for inherited gene mutation for individuals with a personal or family history of cancer. So this bill is about reducing those social determinants of health, those financial barriers that can prevent someone from being able to receive the care that they need. And with that said, that brings me to the end of my conclusion, and I thank you all for listening in.
Lisa, thank you for the excellent job. I think we're going to start our panel discussion. If anybody has any questions, can you please enter it into the chat?
Hi, Neil. This is Linda. I can start off the questions. So for Lisa, are any of the ACS grant programs you mentioned currently accepting new applications?
So there is a link embedded within the slides here, and it tells you the cycles and the application dates for those grants. And so that information has been provided on the screen. If you click on the link, you can be able to identify those grant opportunities and availability to be able to go in and access the funding or opportunities to apply.
Would you be able to put that link in the chat box?
Yes, I can.
Thank you. And if anyone else has any questions, you can also take yourself off mute.
actually have a question for the group. This may be more for Dr. Maga, but anyone's welcome to answer. If there's someone in the community, a patient who's seeing a provider who's not part of a system that includes an academic medical system with genetic counseling services provided, how would that, patient or their provider be able to, kind of initiate a referral, or how do they locate services that may be, within their network? Who would you recommend that they would talk to see if they could begin that conversation about access?
So here at UI Health, we do actually get quite a few fax referrals, which are often, like you're describing, from community hospital systems. I would say that looking online websites, there's many different cancer genetic counseling clinics in not just Chicago, but outside of Chicago. And then for people who may be in other parts of the country, NSGC, actually, if what you're looking for is a genetic counseling appointment, NSGC has a Find Your GC on their website, and you can actually type in where you are, zip code, or the city and the state. You can actually search by what type of genetics you're looking for. So cardiogenetics, cancer genetics, pretty much any kind of genetic service a genetic counselor would give. And it will actually show you all of the providers in your area that provide that service, that take referrals. It will also tell you if they're in person or telehealth, if that's important to the patient. This is something I use all the time. I know we were talking earlier about cascade testing. I've got a lot of family members in different states, and that's how I find a provider for them to see.
Thank you. That's very helpful. Maybe would it be possible to put the website into the chat?
Yeah, I will do it now.
Potentially our attendees could be able to make note of that. Were there other questions or comments?
There is a couple of questions in the comments here. Valerie wants to know, are there any programs for pancreatic cancer genetic screening that may be accepting new participants?
So for programs, pancreatic cancer, as Dr. Perlman mentioned, and I believe that Dr. Maga may have mentioned it as well, it's often included within cancer risk for other conditions as well. So many of these genes can cause cancer or increase the risk of cancer that can occur in different organs in the body, including the pancreas. So maybe the question would be, how would you go about identifying if you have a high risk gene that would be associated with pancreatic cancer? And that's something, I'll turn it over to the group as well, but that's something in the discussion with a genetic counselor or with another provider, they would listen to your own personal and family history and then try to determine the type of genetic risk that may be most likely, and make sure that those types of testing are done if you have a panel test, which would include multiple different types of genes that are tested at the same time. That may be a little bit of a confusing description, so please jump in, Dr. Maga or Neil, if you have a more clear way to answer that question.
I don't have another way to answer that question, but there was another question about colon cancer with hereditary that I just want to do a quick answer to. The question was a family member that had colon cancer, and they were tested negative for both Lynch and familial adenomatous polyposis. So if they've tested negative for it, and it's been within the past 10 years, it is unlikely that they have those two conditions. There are some other more rare conditions that they may have. I had listed those, but those are unlikely. Again, only 5% of people with colon cancer have a genetic cause, so 95% don't have it. So if they do not have Lynch or familial adenomatous polyposis, you should go along the standard screening, which is starting at age 45, or 10 years before the first degree family member had the colon cancer.
And I would just add to that, there are, right now, as we do more genetic testing, we're continually identifying new genes that may be associated with certain types of cancer. So that may change in the future. But we do characterize people under sort of familial cancer syndrome X, which is where they are negative for genetic pathologic mutations that can be identified, but have a family history that's suggestive of a genetic component. And then those patients are screened, as Dr. Perlman mentioned earlier, and oftentimes at a much more frequent interval than people at a quote unquote average risk. So even though the testing may be negative, your providers can still use the information that you have to personalize your cancer screening, not just for colon cancer, but for many other common cancers or even uncommon cancers, if we know that there's something that is prevalent in an individual's family history. Any
And
other, oh, sorry.
I see two other questions. First one from Margarita. What are the opportunities for increasing the capacity of cancer centers or access in the southwest of the state? And I would actually include that to all of Southern Illinois.
That is a difficult question to answer. I would say that the Illinois Cancer Partnership, we try to make a conversation that includes providers and people that work with an advocacy that includes the entire state, including Southern Illinois. A cancer center is a huge endeavor that requires a lot of different levels of resources, from research to certain types of care that can be provided, to access to surgery and radiation oncology and a lot of different things. So in areas that don't have the infrastructure to support that, it's difficult to create what we would traditionally describe as a cancer center. Although many hospitals do have a specific cancer program that may offer certain types of care, and then when they need to do something that's a little outside of what they typically would do, they sometimes refer patients to more distant cancer centers, which unfortunately can require travel and other things that may be barriers. But that is a limitation to the way that we currently care for cancer, and the way our healthcare system is designed. But hopefully, as technology improves, that will improve as well.
And question from Rudy. Has anyone in Illinois thought about having a gene machine, especially for rural and underserved communities? Definitely a plus for health equity.
Mm.
Lisa, that might be a question for you.
Yeah, I haven't heard this specifically about Illinois, but I know that there are opportunities like for this extramural discovery grant. We don't tell investigators what to write, and so there may be opportunity for people to come together to propose such projects. And so, but at this specific moment, is there a gene machine ideal in the works for Illinois? Not that I'm aware of.
Yeah, but anyone who's interested, we put the links in the chat for the ACS sites for the funding opportunities. Maybe partner with a couple of other organizations in your area, maybe submit an application for a gene machine. Would that be a possibility, Lisa?
Oh, definitely. The application can be submitted, whether it's funded or not. I definitely can't say
Right.
that, but there are always opportunities to be able to propose ideas, and those ideas will be peer reviewed, and the best proposal that is submitted and that benefit the community, the cancer community, are the ones that are selected.
Okay.
Um,
And then
if-
Louise does mention, which we appreciate, that Southern 7 Health Department in Southern Illinois offers genetic testing through Invitae. So that is great, Lisa. Thanks for sharing.
You
And
are
Kira-
welcome.
Yeah, again, the options for testing, I mean, ideally, if you have a gene machine, you definitely need a genetic counselor as part of this program because of all the nuances with testing. If you're looking for an easy solution without, in the current climate, it would be Color Genomics, because you're able to do the at-home testing, and they do provide a genetic counselor the cost is fairly reasonable at $250, and you can do a mouth swab or you can do color through a physician's office. And they work with physicians' offices. So immediate solution would be, the easiest would be color, genomics, but all the gene testing companies, Myriad Genetics, Invitae, and Color do a great service. If you form a partnership with them, it's very reasonable.
Yes, and Karen mentioned that in Mount Vernon with SSM, they screen all of their new cancer patients at their center. And if needed, the company they use provides genetic counselors. So that is definitely a great opportunity if you don't have genetic counselors actually in your area. So I just want to take a moment. Thank you for all of our speakers and our host facilitators, Keith and Neil. We appreciate everybody joining. So when you end this webinar, you'll be taken to a survey. It's a brief survey, maybe 1 or 2 minutes. We would appreciate your feedback. And we will definitely share the meeting recording, because I think a lot of information was given and it might help to be able to go through it again at your own pace. So thank you, everybody.
Thank you.
Thank you.